This is Dr. Robert Gish. Greetings and welcome to the CME-CE certified activity titled Integrating the Latest Advances into Clinical Practice, Data and Expert Insights from the 2016 meeting on gastrointestinal cancers in San Francisco. This educational activity is jointly provided by the Postgraduate Institute for Medicine and Access Medical Education, and is supported by educational grants from Novartis Pharmaceuticals, Taiho Oncology, Inc., and Lilly. My name is Dr. Robert Gish. I'm a clinical consultant professor of medicine at Stanford Hospital and Medical Center in Stanford, California, senior medical director at the UNO Certified Liver Transplant Program at St. Joe's Hospital in Phoenix, Arizona, and a clinical adjunct professor of medicine at the University of Nevada in Las Vegas. My disclosures include consulting fees and speakers bureau from Bayer Pharmaceuticals Corporation. Our discussion today will include the most exciting and compelling data concerning hepatocellular carcinoma from the 2016 gastrointestinal cancers meeting and insights on how these clinical advances may be practice changing. So let's begin. The first study I'd like to highlight is a study concerning doxorubicin and sorafenib. Now let's step back in history just a short time. A phase 2 study was published in JAMA by Dr. Abu Alfa in 2010 that compared doxorubicin plus sorafenib versus doxorubicin alone. As you recall, in this small study of about 100 patients, the median overall survival was doubled from 6.5 months to 13.7 months. This led to justification to develop a much larger phase 3 study to determine if doxorubicin still had a role in managing our patients. Doxorubicin historically was used as monotherapy intravenously for about 2 decades to manage HCC, both in the U.S. and worldwide. And interestingly, for a time was the only medication that was a systemic therapy for liver cancer. The data to support doxorubicin has been scant in the peer-reviewed medical literature. Abstract 192 from Dr. Abu Alfa, entitled Sorafenib with Doxorubicin, the results of a phase 3 trial. Overall, adding doxorubicin did not appear to benefit sorafenib therapy in patients with advanced HCC. Now let's take a look at the data in a little bit more detail. Median overall survival was 9.3 months for the combination therapy compared to 10.5 months for sorafenib alone. It's important to note that this crossed a threshold of futility, and the DSMB halted this study with an enrollment in the range of around 350 patients. Additionally, about 38% of patients receiving doxorubicin plus sorafenib had grade 3 or 4 hematologic adverse events, compared to just 8% of patients receiving sorafenib alone, compared with 8.1% of those patients receiving sorafenib alone. This may be the end of the use of doxorubicin for HCC, but I'll comment on that just a little bit later in this podcast. Now, we're going to give a little bit of background on an important medication called Savant Anub. This is an experimental anti-cancer drug that was developed to target MET. It was determined to be a highly selective MET inhibitor, but the mechanism of action is still unclear with tebatinib and may involve other mechanisms, since tebatinib displays cytotoxicity activity via molecular mechanisms that are independent of its binding to MET. Now let's just go back in history also just for a short period. Santoro in Lancet Oncology 2013 looked at the treatment of patients with liver cancer, high MET in tissue, and tebatinib in this phase 2 study compared to placebo had an overall survival of 7.2 months compared to 3.8 months for placebo alone. This is an important determination. This led to tebatinib being developed and moved into phase 3 studies. But let's look at this data in a little bit more detail in abstract 197 from Mimosa. They did a number of very important analyses with data extracted from the phase 2 randomized clinical trial, and they found some important findings. Now, we already know that alpha-fetoprotein is a risk marker for future liver cancer development. But if you have liver cancer, alpha-fetoprotein helps with current prognosis. Chance of progression, is it poorly differentiated, chance of recurrence. And like AFP in this Savant Anub study, high MET, like high AFP, indicated a much shorter survival in the Savant Anub study, both in Savant Anub and in placebo. Now, another important finding was that circulating MET increased over time with sorafenib exposure. So something's happening with sorafenib, and this may explain sorafenib resistance in that as MET increases, this may be another pathway for tumor replication and maybe an escape route that allows the tumor to bypass where sorafenib inhibits through the RAF-RAS kinase pathway. Now, another important finding in this study is that patients on tumatinib with greater than a 10% reduction in circulating MET had an overall survival of 13.3 months compared to those who did not have a 10% reduction at 6.3 months. So circulating biomarkers, tissue biomarkers may all be important, not in just this specific medication, but with other medications that are being developed for liver cancer. More to come on biomarkers and guiding therapy. Now we're going to move to a different subject, PD-1, PD-L1, extremely hot topics in oncology today. This protein death receptor or protein death ligand is very involved in immune control. Not just immune control of cancer, but also immune control of things like viral hepatitis, including hepatitis B, where exploratory studies are ongoing today. But if you inhibit this receptor or this axis in different types of cancer, you de-repress the immune system, and as you move up immune activity, an anti-cancer effect takes place in different types of tumors, such as lung cancer. Now, this is being explored in liver cancer because in the liver, there are Kupffer cells, which express PD-1, which may have anti-tumor activity, tumor-associated monocytes as well. And if you can activate the immune system, you may have another pathway alone or in combination to battle hepatocellular carcinoma. And this has been proven in marine models. Now, from a historical perspective, at ASCO 2015, El-Khoury et al. Had a study, phase 1-2 of 47 patients, looking at blocking PD-1 with nivolumab. Now, these were Child's A patients, but with advanced disease, typically with portal vein thrombosis or metastatic disease outside the liver. 70% approximately of these patients had been previously treated with sorafenib. In this study, overall survival was 62% at 12 months. An expected survival, even in treated individuals with sorafenib monotherapy, would have been 30% in a similar patient profile. This has led to further explorations in using PD-1 inhibitors or PD-L1 inhibitors, moving towards phase 3 trials. But now we're going to talk about, is that really justified? In abstract 289, Modi took a look at PD-1 and PD-L1 expression and molecular associations in various hepatobiliary tumors. Now, what was interesting here is that 4 to 18% of the hepatobiliary tumors express PD-L1, and 29 to 45% of these tumors express PD-1. Now, as we develop these clinical trials, big question is there is, should we be guiding therapy in the clinical trials based on PD-L1 or PD-1 expression? Should we also sub-select patients or randomize patients, select those patients randomizations based on this expression? We know that there's an extreme tumor heterogeneity with different gene expressions, receptor expressions, kinase expressions, and we just talked about MET expressions a few moments ago, with one of the other studies that was here. So this is something that will need to be looked at prospectively. Now, interestingly, in this tissue analysis, there were no specific mutations in the tumors that were associated with PD-1 positivity or negativity. But there was an increase in TOP2A, topoisomerase 2A expression, which is a marker of both cellular proliferation, and, interestingly, anthracycline sensitivity. So it's possible that doxorubicin is not dead, but may come back in another form in patients that may have PD-L1 expression. So important studies, tissue analyses, determining tissue heterogeneity, how to design future studies, and ultimately, should we be doing tissue biopsies on all of our liver cancer patients? Are liquid biopsies enough? Are circulating tumor markers sufficient? All of these will be looked at in current and developing prospective studies, especially the large phase 3 studies, which will help us probably the most. Now let's look at another important area. Historically, in managing liver cancer, external beam radiation therapy has had a very small role. Maybe 1 to 3% of patients actually make it to the radiation oncologist. I, as a practicing hepatologist who've taken care of a few thousand liver cancer patients, have really rarely seen a role for radiation therapy. Now, there's been huge improvements in how we guide radiotherapy for our patients, and SBRT, the stereotactic body radiotherapy, has really matured for a variety of different tumors, and it's being looked again closely for patients with hepatocellular carcinoma, specifically unresectable. Abstract 322 by Young took a look at a large population and looked at what would be the tumor response. Now, overall response with SBRT for all patients in the study at 1 year was 67% and 62% at 2 years. Very interesting, even some patients with large tumors. Progression-free survival, 53% and 38% respectively at 1 and 2 years. The median PFS was 13.7 months, with 13 patients, 27% of the total, undergoing further treatment. 4 of those patients eventually underwent liver transplantation. In summary, SBRT provided high levels of local control for patients with HCC with moderate to large-sized tumors. Clearly would be another option to add to our near-term armamentarium for patients with HCC, although large randomized controlled studies would be ideal. A little bit more information from this SBRT study. Overall, again, I'd like to highlight that this is a retrospective study of 49 HCC patients that were looked at between 2011 and 2015 at the British Columbia Cancer Agency. Now, natural history is very important. Natural history of HCC was looked at in abstract 416 by Al-Shamsi. Now, as you recall, we don't use the TNM system very commonly for HCC. We're typically very much focused on BCLC in clinical practice. But this study looks specifically at T1 lesions, which is less than 2 centimeters, N0, M0. This is a large-scale U.S. study, and they highlighted what we know, 20% 5-year survival rate. We need to do much better than this. If you take a look at a similar group of patients in Japan and follow them out 5 to 10 years, you're going to see survival rates in the 50+% range. Now, this is a correction even for length and lead time bias, and the determination is that finding lesions at small size and intervening with potentially curative therapies, including resection, liver transplant, but as you recall, ablative therapy in these small tumors, especially percutaneous RFA and microwave ablation, can result in cure in a significant, I'm saying small but significant at 20% range number of patients. Now, in this study, 2 things were very important. Surgery numerically had the best overall survival, but sorafenib had good long-term survival rates that were numerically similar to the surgical resected populations. Clearly, we're going to be selecting different patients for surgery versus sorafenib, but these overall survival data with sorafenib was quite impressive. Now, the most important thing from this study to me is that 50% of the HCC patients were non-viral, both non-alcohol and non-viral. This, to me, supports at least the theory that fatty liver in NASH is emerging as potentially as the first or second most common cause of HCC in the United States. So, in summary, the role of SBRT is in evolution. Larger controlled studies will help us define the role of SBRT in patient selection. Doxorubicin is at least temporarily closed as a single or combination therapy for HCC, but reemerge in the future in patients who appear to have some type of selective sensitivity. PD-1 and PD-L1 inhibitors are being explored in detail, and tissue and liquid biomarkers of PD-1 and PD-L1, quote, sensitivity, end quote, will be important to help determine who should undergo therapy with these specific inhibitors. The Savant Anub studies have helped us define both tissue and serum biomarkers that may be helpful in guiding not just this specific medication, but also other medications in the future. We are shifting back to both a tissue biopsy frame in managing HCC patients, and hopefully we will be able to detect and use tools of blood markers for HCC management. And with that, we'll conclude this educational activity, and thank you for your participation.